Respected teachers and dear participants, good evening. And today is our 12th session of ECG. The topic is wide complex tachycardia, and our today's presenter is respected Dr. Rafique Ahmed sir. Now I kindly request Professor Abdul Chowdhury sir to introduce and say something about our respected Rafique Ahmed sir. Wadud sir, please.
After these 12 classes, and before that, everybody knows Rafique sir. I don't have to introduce him anything anymore. But one thing I can say, all of us, Atahar bhai, myself, Dr. Professor Mohsin, yourself, everybody calls him our guru. And that's the thing. Medicine as a whole, it's a guru dhara bidya. The parampara, I'll be using that Bengali term, that has to be maintained. And in that rung of things, Dr. Rafique Ahmed is our mentor. Sir, welcome to the session, and please start your lectures.
Thank you. Assalamu alaikum. Welcome everybody. We have senior professor, Professor Jalal here. And then we have new participants from Faridpur. Welcome to everybody. What's happening? My share screen is not share screen. Okay. So normally what we do is that we do my lecture followed by question and answer session. But today I'm going to combine it so that I will have only one session, and I would like participants to take part in it. And so I'm going to start with today is wide Qrs tachycardia. I think we have done this topic before, but I think doing it again and again helps. Professor Mohsin last week did WPW syndrome, and he touched part of the wide Qrs. That's an unique wide Qrs tachycardia. We have looked at hyperkalemia, and if somebody has hyperkalemia, that can produce wide Qrs tachycardia in the setting of sinus. That's another unique kind of, but we are going to focus whether it's VT or SVT. So I'm going to start with this ECG, and I would like the participants to answer. So we have the this multiple choice screen, please.
Sir, we are bringing it. Sir, just give us. Yes, sir. Here it is.
And we'll give 30 seconds for everybody to answer. Please feel free to answer whatever you think, but don't do it randomly. Just when you answer any question, just you have to put some thought process in it, why you are saying it. That understanding can be right or wrong. It does not matter. As long as there is a thought process behind any answer, that's a good thing. So, Tushar, please let me know when it's 30 seconds over. Okay. So I think 93% said ventricular tachycardia, and number C was 7% said atrial flutter with underlying bundle branch block, left bundle branch block. I don't disagree with both of these choices, and that's where it is. So when you look at an EKG, if it is wide Qrs, if we do not know it, it is ventricular tachycardia unless proven otherwise. However, having few things, either some kind of algorithm or an old ECG helps. So this patient, of course, the setting is a 44-year-old male with non-ischemic cardiomyopathy, presence with palpitation. And the interesting part, so if we look at, so this ECG was done January 8 at 2005 at 8:33 a.m. Heart rate is 200. And when the rate slows down, you can see that this was actually half an hour later, it was atrial flutter. My pointer here, you can see the flutter waves. So that was atrial flutter with 1-to-1 conduction. This is 2-to-1 conduction. Why that was not VT? Because the Qrs morphology, lead by lead, is same. I'm going to go back. If you look at the other ECG, this ECG lead 1, lead V6, this ECG, same morphology. So having an old ECG or a follow-up ECG is helpful in diagnosis, but I agree with the choice number one, which is 93% said VT. That's an acceptable diagnosis, even though it was not the case. So I have another ECG now. So I have multiple choices. Can you get that?
Yeah.
We'll wait 30 seconds. And I'll keep talking while I'm doing this. I'll keep talking while I'm doing this. The previous ECG tells us something that, I mean, an ECG which looked exactly like ventricular tachycardia was not ventricular tachycardia. And the same can be other cases where we think it's supraventricular tachycardia, but it's not supraventricular tachycardia. The most important thing in the management of this patient will be really to talk to the patient and decide, like the first patient, if he is hemodynamically stable, if his blood pressure is fine, if he is conscious, then we have a little time to think about it instead of jumping into electrical cardioversion. Of course, on the other hand, if the patient was hemodynamically unstable, then definitely we have to do something immediately.
So the poll result?
Okay, good. I think our ECG lecture is working because if you look at this here, majority answered C,
Yes,
which is SVT with right bundle bunch block. There is 16% said ventricular tachycardia, sinus tachycardia with underlying right bundle bunch block, and then atrial flutter with right bundle bunch block. And I'm going to discuss all these choices. Please leave these choices on here. Number one, ventricular tachycardia, I will take that diagnosis because it's the white Qrs tachycardia with a rate of 219 beats per minute. That is acceptable choice. B is sinus tachycardia with a rate of 219. That probably is not an acceptable choice because for the sinus rate to go up to 219 is very, very difficult. Somebody has to be very, very sick. Number C, we will come to that. Number D was atrial flutter with right bundle bunch block. If it is atrial flutter, then it will be 1-to-1 atrial flutter. That means it's a very slow atrial flutter. Or if it is 2-to-1 flutter, it's very fast. Now, one of the things that if we look at lead V1, there is a small R followed by big R. That suggests that it's probably a supraventricular rhythm. And of course, I had the benefit of having this patient's 12-lead ECG. And I brought this up, both of this ECG, because of the one reason that having availability of an older ECG, and this ECG shows exactly same as during the tachycardia. So what we do is that if I get these two patients in the emergency room, I will immediately try to find out if there is any old ECG to match it. And computer is coming very fast. We have fast access to the ECGs. I'm sure sooner or later in Bangladesh, we will have access. So quickly looking at the old ECG, or if the patient has old ECG, comparing it helps. So comparing this ECG with the other one makes the diagnosis SVT with underlying right bundle branch block.
Sir, I have a question, sir.
Yes.
Sir, previous ECG, sir.
Yes.
Sir, Techie.
Yes.
Sir, if we follow that, sir, what will be the morphology of the Qrs complex in V1? Whether it is monophasic, now we should tell it, taking the...
The question is, Atahar saying, is it monophasic? But I think there is an R wave here. It's just that if I go to the next ECG, I'll tell you, you are absolutely right.
Rafique bhai,
yes.
Rafique bhai, একটা second.
Okay.
বলবো কিছু?
Yes, go ahead.
আমি বলি যে দুইটা পারপাস ইকেজির আমি ফেলোদেরকে বলি, একটা হলো বোর্ড পাস করা আর একটা হলো পেশেন্ট ম্যানেজমেন্ট করা। তো মনে করেন এই ইকেজিতে আপনি একটু আবার ওইটা রিভিউ করবেন যে হাউ টু ডিফারেন্সিয়েট এসভিটি and VT, like আমি যেটা বলতে চাচ্ছি lead 1, the early depolarization, like from beginning to the peak of the depolarization, very narrow. And then there is no capture beat, fusion beat. There is no concordance. এগুলো একটু আপনি বলেন আবার।
No, it's coming. It is coming.
আচ্ছা ঠিক আছে।
It is coming. So,
আচ্ছা আর আগের পেশেন্টটা যেরকম রফিক ভাই আগের পেশেন্টটা আচ্ছা
it's coming. It's all of these are coming. Hafiz. So, coming to the question of Atahar, it's an important question because it looks monophasic. But if I look at this one, it's not our typical, typical right bundle R, there is a deep S, but this is almost in the isoelectric. And so I think when it became tachycardic, it almost looked monophasic. Absolutely right, Arthur. So now this question, Hafiz, I'm coming to your points. All of them will come in sequence. So this ECG now. I have given the heart rate in the bottom. Its heart rate is 210 beats per minute, and I have choices. This is a 72-year-old male who has coronary artery disease, has a DDD pacemaker in place, and came with a syncope. And this is the ECG. Okay. So the choices are sinus tachycardia with underlying right bundle branch block. Number B is ventricular tachycardia. Number C, atrial flutter with underlying left bundle branch block. And number D, few said sinus tachycardia with hyperkalemia. Again, I'll come to that point that sinus tachycardia at this very fast rate is very difficult. I would like the panelists, if they have any comment, because I'm not going to have question answer session today. So if you want to jump in, all our panelists, I'll be very happy.
Sir,
So sinus tachycardia, yeah, go ahead.
Sir, I have two observations, sir. Sir, first of
Yes.
all, in V1,
Yes.
sir, whether V1, the first, second, third, that is third, fourth, fifth, sixth. Sir, are these the P wave, sir? Does it indicate the?
You are talking about this and this.
Sir.
It's a possibility because what Atahar is pointing out that if you look at this, can you turn up the background off, please? So if there is nothing here, there is something here. Maybe there is a P wave, but I cannot. If somebody challenges, but it is actually there in other leads also. So there is a possibility of P wave. The
এই
question
পি ওয়েভ নিয়ে সমস্যা আতার ভাই আপনারা ইপিরা এই যখনই সুবিধা হয় পি ওয়েভ বলেন এটা পি ওয়েভ যখন অসুবিধা তখন বলেন না হাকিকত
No. Okay. So the question is it right bundle branch block? Maybe, but it doesn't show the RSR pattern in this one. Again, sinus tachycardia at a rate of 200 beats per minute is very difficult. And then, as Hafiz pointed out, if you look at lead 1, it does not look like right bundle. So that takes the first choice out. Atrial flutter with underlying left bundle branch block is out because it is not left bundle branch block. Even if it is anything, V6 looks like left bundle, but V1 does not. Lead 1 does not look like left bundle. Sinus tachycardia with hyperkalemia, I put it just for the fun of it. This is too beautiful in ECG to be hyperkalemia. Hyperkalemia will have ugly looking ECG, almost sinusoidal at this rate. And so I thought maybe ventricular tachycardia. Why? Because it fulfills one criteria.
sinus tachycardia hyperkalemia এত ফাস্ট রেট হবে না
Exactly. Absolutely right. Because
আর
the point
আপনি নেক্সট টাইম রফিক ভাই ওই হিস্ট্রিটা দিয়েন না সিএডি দেখলে
of course I'll give the history. Okay, so the point is that, so let's look at what criteria would I? So there is criteria that if there is concordance in precordial lead, that means if the QRS complex, all of them are looking up or all of them looking down, that is ventricular tachycardia. And this ECG is concordance. That means you see V1 is positive, V2 positive, V3, V4, V5, V6, all of them positive. And that makes the diagnosis of ventricular tachycardia. You will never see that in SVT with any kind of aberrant conduction. So the next one, so this ECG, how about this one? We have a couple of choices here. And below is the rhythm strip when the patient converts to sinus rhythm. Heart rate is a little bit less than 140 beats per minute. I think it was around 138 beats per minute.
Sir, 40%.
Okay, sure. So we have the choices. One is sinus tachycardia with left bundle branch block. Sure, lead V1 and V6 look like left bundle branch block, but lead 1 does not. I'm going to come back to this point. Second choice, 34% was ventricular tachycardia. We'll come to that. Number C, atrial flutter with underlying left bundle branch block. It's a possibility. So that will be an atrial flutter, a very slow atrial flutter. Again, sinus tachycardia with hyperkalemia. I mean, as Hafiz mentioned, it is difficult to get sinus tachycardia during hyperkalemia. It is more normally you get bradycardia and then waves are sinusoidal. So let's look at it. What criteria can I use in this? One of the criteria that says that onset of the R wave to the deepest point of S wave more than 100 milliseconds in any precordial lead, that will make it VT. So let's look at this one. This ECG. What I have done, I have expanded this V4, and you can see from the beginning of the R wave to the deepest of the S wave is about 130 milliseconds. So if in any precordial lead, from the beginning of the R wave to the deepest point of S wave is more than 100 milliseconds, that's VT. So no question, this was ventricular tachycardia. And these are the criteria that we should be using it for diagnosis. Now, so this is VT. Now, let's look at next criteria, ECG. How about this one? The heart rate I have written down in the bottom is 130 beats per minute. It's a 17-year-old male from one of the hospitals that I used to work. Hafiz, are you still online? Okay. I'd like a comment from our panelist. Any comment about, so sinus tachycardia with underlying right bundle branch block. Majority said, 42% says ventricular tachycardia, atrial flutter with bundle branch block, or junctional tachycardia with underlying right bundle branch block. Any panelist, any comment about this?
I have a comment, sir, from Govindo.
Yes, please.
Sir, white complex regular tachycardia. Here in AVF, we have to see in the capture beat seems to be this P wave and Qrs complex. And others points is LBB morphology, LBB and RBB both morphology,
Yes.
but wide complex tachycardia and capture beat, but not concordance in chest lead, which is points against points, but most points in favor of VT. Wide
Thank you.
complex tachycardia.
So basically, the tachycardia is 130 beats per minute. Then, of course, in a young person, if you suddenly look at this ECG, it looks kind of narrow. But actually, the duration of QRS is 154. Lead V1, it looks like left bundle. But in chest lead, it looks like a right bundle. So if you look in the bottom rhythm strip, and if I keep following it, you will see something. So this is actually a right bundle with left axis deviation. QRS axis is minus 70, relatively narrow QRS. And if I put this, I ask the question, is there evidence? I have put some stars here. If you can see, even the Hafiz was making fun of EP doctor, but you can see that there is a P wave here, which is absent here. It's absent here. There is another P wave here. And maybe there is another P wave here, and there possibly another P. These P waves are very, very clear, and they are not capturing the ventricle. So the ventricle is independent of the P wave. So there is AV dissociation. And if you can prove AV dissociation, that's 100% conformity of ventricular tachycardia. Unfortunately, AV dissociation is very difficult to see as the rate gets faster. This most likely is a left-sided fascicular ventricular tachycardia, which is very, very common in Bangladesh. It's not as much common in this country. So the point that we are trying to make is there AV dissociation? If the answer is yes, that's ventricular tachycardia. And the previous patient had AV dissociation, and so it's ventricular tachycardia. And then another thing that Dr. Gobindo mentioned, that sometimes we see what we call fusion beat. If you see this tachycardia, this is a slow VT, and there is a P wave here, and look at the QRS, and this QRS morphology is a little different from the previous one or the afterwards one. And this is in between a normal beat and a ventricular beat, which is a fusion beat. That means it captured the ventricle partially and fused with the ventricular complex, and we got the fusion beat. So presence of AV dissociation, presence of fusion beat is more or less confirmatory of ventricular tachycardia. And sometimes we see what we call capture beat. That means the Qrs complex is exactly like the sinus beat. How about this one? Again, I want the choices. The heart rate, again, is 135. And this is the rate that we have to be very, very careful, because it overlaps so much with sinus tachycardia, with 2-to-1 atrial flutter. It can be atrial tachycardia, or it can even be slow ventricular tachycardia. Those are the problems that we always face in this group of patients with this little bit slower heart rate. Slower heart rate is the one where we miss. Same as acute MI. If somebody comes with 35-year-old male comes in, we are more likely to miss acute MI in a 35-year-old than a 55-year-old person or 60-year-old person. Is that right, Wadud? What do you think?
Very true.
So when we look at any patient, if anybody comes in, we must keep an open mind. Okay, so this is good. 74% said ventricular tachycardia. 9% say sinus tachycardia with right bundle bunch block. Sinus tachycardia, right bundle bunch block, septal MI, and atrial flutter with underlying right bundle bunch block, number 4. Now, can it be sinus tachycardia? It's a possibility because the rate is 135, and it looks like a right bundle bunch block. Can it be sinus tachycardia, right all septal myocardis? It's a possibility because there is a Q wave in lead V1. Atrial flutter, maybe, with 2-to-1 conduction with some right muscle. But here, what we need to do is to see if we can find any other feature that so far we discussed. Number one, is there concordance? No, there is not concordance. Number two, is there AV dissociation? It is very, very difficult to find any AV dissociation in this. If we look for it, and Hafiz said we can always make it up as a EP doctor, but we should not do that. But one of the criteria that we can use is morphology criteria. So let's look at morphology criteria of ventricular tachycardia. So is there morphology criteria for V in lead V1 and V2? These are the criteria. If something looks like a right bundle, which this ECG looked like, if we find monophasic R wave in V1, that's VT. If we find a Q followed by R wave, that's VT. And then or RS pattern. And then in V6, we can find all this pattern, Q wave or QR pattern on RS ratio less than 1. So let's see what this patient had. If we look at lead V1, there's a big Q wave with R wave. So it fulfills this criteria. In V6, the R and S ratio is close to 1. The other thing, if you remember, in the first criteria, one of the criteria we said that in any precordial lead, beginning of the R to the deepest point of S wave, if it is more than 100 milliseconds, that's VT. And in this case, this patient had 110 milliseconds in V6, beginning of the R wave to the deepest point of the S wave. So based on this criteria, right bundle, Q and R pattern in V1, and from beginning of the R wave to the deepest point of S wave in one of the precordial lead more than 100 milliseconds, that makes it VT. This looks very slow. And I'm going to give you follow-up ECG on this patient. So this patient was started on amiodarone, came back with a similar tachycardia, but a slower rate. And then one can question, is it really VT? I'll show you what we did. We looked at the intracardiac recordings. This channel is the atrial electrogram, and this is the ventricular electrogram. You see the ventricular rate is a little bit over 100 beats per minute, and these atrial P waves are marching through it. So we clearly proved, and this is the learning process that we always exercise, that just because Dr. Ahmed said this is VT, don't believe it, or Professor Wadud said, don't disbelieve, but also we need to confirm our knowledge. This ECG, we were very sure this is VT, but we also looked at the intracardiac to reinforce our knowledge. And that is the learning process that we need to continue doing it. And I'm still doing it. I'm still learning this ECG as I move along. So the morphology criteria with the right bundle, it fulfilled that criteria. How about left bundle? How about this ECG? Again, I'm going to give this ECG and read the diagnosis, please. This looks like in chest lead, it looks like left bundle morphology. So far, we are all this ECG that we are showing have regular R to R interval, which makes it easy to diagnose.
Rafique bhai,
Yes.
ওই কিছু জিনিস বলবো যেগুলো আপনারা পছন্দ করেন না, যেমন
Hafiz, English, please.
Acha.
So, outside Bangladesh.
Oh, sorry. So I was joking with Dr. Ahmed that there are some things that the EP guys do not like, such as if the heart rate is 150, then, and it is wide complex, always entertain this thing that it may be a tail flutter 2-to-1, and look at few clinical aspects, because and I disagree with Rafique by one thing, because the EKG scoring system in the cardiology board, he gave sinus tachycardia as an option, and he was very liberal in terms of saying, yeah, that is a differential. But if you write sinus tachycardia, you may get a negative score. So we need to be aware that, the white complex tachycardia, like this EKG also, when you are at 150, please be aware that you are in that zone. I know that EP guys, they don't like this comment, but the clinical part, this is not cheating, but somewhat cheating. Clinical part and the rate.
Okay, so what Hafiz was trying to say, and I have emphasized this again and again in many lectures, that in American Board of Internal Medicine, there is no negative marking, except in few cases. If something is ventricular tachycardia, and I call it sinus tachycardia, I can harm the patient. If I say sinus tachycardia as ventricular tachycardia, I'll get 0. But if I call ventricular tachycardia as sinus tachycardia, I'll get -1 because my patient can die. Same is true for acute myocardial infarction. If there is a pericarditis, I call that acute MI, I will get 0. But if it is acute myocardial infarction and I call it pericarditis or normal, I'll get a -1 because I have endangered the patient's life. So this patient, of course, majority gave answer of ventricular tachycardia, and then some gave sinus tachycardia, and then others atrial flutter with underlying left bundle branch block. So let's look at it. I mean, first of all, I'm going to go serially. This ECG is a white Qrs tachycardia. It does not fulfill the criteria of concordance. So we can't use that because it's not concordant. Number 2, AV dissociation. I cannot see AV dissociation, or it is very difficult for me to define whether if there is AV dissociation. So we can't do that. This patient is not right bundle branch block. It has left bundle branch block, and I can use left bundle branch block morphology criteria. And what are those criteria? That if I have enlarged this bit, and you can see that this initial R wave is close to 70 milliseconds. Same in lead V1. If you are left bundle branch block with sinus tachycardia, this will be narrow. It will be less than 30 milliseconds. And that is the point that makes it ventricular tachycardia. And also this patient also have in lead V4, from beginning of the QR wave to the deepest point of S wave is also long. It is more than 100 milliseconds. So based on both criteria, this is ventricular tachycardia. So this is the second one, that in V4, beginning of the R wave to the deepest point of S wave is about 130 milliseconds. That makes it ventricular tachycardia. So when you look at this ECG, just don't look cursory, just look at rate carefully. And the reason I'm putting this ECG is, if I gave this ECG at a rate of 190, 200, everybody would say VT. But this is a rate where there is borderline rate. And that's when we get confused. So,
Sir,
yeah.
Sir, back to the ECG,
Yeah,
sir.
just 1 second. Yeah.
Sir, 2 questions, sir. Actually, which lead we should choose for calculating the R2S interval, sir? Number
Okay.
1. And sir, in this ECG, sir, lead 2.
Yeah.
Sometimes you are confused. There is a nose at the bottom of this, sir. Sometimes you are confused whether this can be the P wave or not.
Okay, in lead 2.
Lead 2,
Yeah.
sir, there is a nose.
Exactly. So the question was 2 questions. 1, this criteria that I'm measuring from beginning of R wave to the deepest point of S wave, 130, this will apply to any chest lead. If there is a RS pattern, it has to be a RS pattern in any chest lead. If it is from the beginning to the deepest point of S wave, if more than 100 milliseconds, that's VT. And
Right,
the
sir.
initial R wave part will only apply for V1 and V2. So I'm coming back. So the initial R wave part, more than 30 milliseconds, only did V1 and V2 because in left bundle, we have a narrow R wave. Now, what Atahar is talking about, this thing, is this a P wave? I don't know. If this is a P wave, this is a retrograde P wave. because it is following the QRS complex, or it can be just part of the QRS complex. But I think maybe you're right, Atahar, that you see there is in lead 1 also there is a notch here, but it's absent. I can't see it very clear, so it's a possibility.
Right.
I cannot bet on it. Sometimes I'll say definitely it is, but there is some distortion in lead V1 also. It can be a retrograde P wave. Remember, this is a relative. I think this is a young person. It's a 38-year, it's a relatively young patient, so he has good retrograde conduction. So this fulfills morphology criteria, and if the morphology criteria, we call it VT. Now, if none of this fulfill, let's look at this ECG. This is the white QRS tachycardia at a rate of 169 beats per minute. It does not fulfill any of those morphology criteria. If I look at beginning of the R to the deepest S, it's 80 milliseconds. The initial R wave in V1, V2, we can't see it much, but in V3, the R wave is less than 30 milliseconds. So this is actually an SVT with left bundle branch block. How do I know? First, the morphology criteria. Secondly, we did an EP study on this patient. This was induced during EP study. So we had SVT with left bundle branch block. Now, as I mentioned, all of them, so if none of these criteria fulfills, then we'll call it with SVT with aberrant conduction, right or left bundle branch block. Now, so far we have looked at all regular RI. This ECG was posted on Facebook by Dr. Saif Tipu from Coxbazar, right? And I have chosen the answers that everybody answered. And I would like you to, the audience, to give me what they think about it. I mean, it's interesting ECG. I mean, we always encounter this kind of ECG, and this ECG has become more confusing, especially when the patients are on telemetry floor and we are looking at the telemetry screen, and it can be scary. But please remember, it doesn't matter how ugly the ECG is. Please talk to your patient. If the patient is awake, alert, hemodynamically stable, take your time before you make any decision to take care of this problem. Okay. So, fair distribution. Anybody, I want the panelists to comment on it. So, atrial fibrillation with left bundle branch block, sinus rhythm with non-sustained VT, and then polymorphic ventricular tachycardia, good bit. Number C and number D, all of them have choices. Anybody? What is any comment?
Can I say something, sir?
Definitely, please.
So this is not atrial fibrillation, as there are some sinus bits seen in between the irregular bits. In the lower panel, the second one, third, fourth, fifth, sixth one, and again like this, there are some P waves. Yes, sir.
Okay.
And followed by Qrs Complex.
Jamil, can I interrupt? I want to re-emphasize. So Dr. Jamil is saying, yes, there is irregularity and you can think of atrial fibrillation, but there is P wave here, and I can see another P wave here, and there is another P wave. So it's not atrial fibrillation. Then the question would be, is it possible, Dr. Jamil, that this little bit of it, that is a short run of atrial fibrillation?
Yes, sir. But the Qrs complex little bit wider than the sinus bits.
Okay.
And this may be a short run of VT, sir.
Okay.
Can I say something, sir?
Yes, please.
The beat which are associated with P wave, it shows the PR interval on all those beats are very fixed. That means this is actually a sinus capture beat. The ventricular complex following the sinus beat. Now, that complex has a spike in front of it. So that suggests that this is atrial cell ventricular pacing. But the beat thereafter is a little bit irregular, and that comes in paroxysms. So that could be either
Parkinson of atrial fibrillation or non-sustained VT. But those beats are themselves seems to be regular. So I would prefer its non-sustained VT. Basic atrial sensitive ventricular pacing.
Sir, I have a point against VT, sir.
Okay.
Sir, the sinus beat,
Yes.
the tachy beat and the sinus beat's morphology is almost same.
Yes.
If you have the VT, that should be defined.
Okay.
Like the lead one, sir, all the leads, sir. There is the sinus beat, the morphology of the other, the duration is variable, but the morphology is almost similar. Sir, if you have the VT, it should be different, sir.
Okay. I agree with you. So I want to take out few things from the picture. Number one, polymorphic ventricular tachycardia. Please remember that to define polymorphic VT, you need to look at a single lead. So what I have done, when I remove all this, and you look at lead 2 only, there is no polymorphism. All the QRSs are looking down. And I'm sure panelists here will not disagree with that point. To call it polymorphic VT, if this beat was looking down and this is looking up, then something in midway, then I would call it polymorphic, more than 2 morphology.
Yes, sir.
This is not polymorphic VT. So that's out. Second question is, why did some of our audience call it atrial surge ventricular pacing? I think what they are looking at, there is a P wave, there is a sharp complex here. But if you look at that complex is coming after beginning, and I think this is part of the QRS complex. Other possibility may be there is an artifact in lead V1. Maybe you are thinking as pace beat. So I don't, but if you look at lead V2, V3, there is no pacing spike at all. So I think this is an artifact. So this is not atrial surge ventricular pacing with non-sustained VT. So baseline rhythm is sinus. It is possible that this can be atrial fibrillation with conducted, but the QRS morphology is slightly different from it. So let's look at it. This is what I thought, that there is a P wave, there is a Qrs complex. These beats are a little different. These are ventricular. Again, maybe there is a P wave here with conducted, ventricular beat, sinus beat with conduction, and then ventricular beat. Look at it. Why it is ventricular? Look at lead V5. It is a totally different morphology which compared to this one. So I think it's VT. And if you look at lead V1, I have enlarged this bit 1 and bit 2. Bit 1 has a beginning R wave which is very narrow, less than 30 milliseconds. Bit 2 has R wave which is more than 30 milliseconds. That means the second beat was a ventricular beat, if I go back with my other criteria. So my diagnosis was, this is underlying sinus rhythm with runs of non-sustained ventricular tachycardia. And there is maybe a little irregularity, and that irregularity sometimes you can see in ventricular tachycardia. Anybody want to disagree with me? I'm fine with that too. What do you think? Did I give a right explanation? Any other question?
No, sir, I agree with you, sir, right now.
Okay, good. So I borrowed another ECG from a publication, and this is the ECG. And again, I'm giving some choices. I'd like the audience to answer. This rate is around 120 beats per minute. It's a wide QRS rhythm and looks fairly kind of irregular. It is irregular. Okay. Anybody, Jamil, any comment? Or Wadud?
waves are seen occasionally, so it's not atrial fibrillation.
Okay, so I'm just re-emphasizing that this looks like a P wave where my arrow is, right?
Yeah, and
maybe this one. The lead V1, V2, you can see a P wave, so it is not atrial fibrillation.
So that means it either atrial fibrillation, RPP, or ventricular tachycardia. But ventricular tachycardia should have been much regular.
Yes. So atrial fibrillation left bundle doesn't fit because it is not left bundle. Whatever it is, V1 is positive. So if it is anything, it is right bundle type. Sinus rhythm with right bundle is an option, but it's very irregular. Atrial fibrillation with the right bundle is a possibility. Ventricular tachycardia. So the question is, does it fulfill any of our previous criteria? Kind of concordant, but not totally. But it does not fulfill the right bundle criteria.
No.
It could have been ventricular tachycardia if it is regular. But this is the part that we always think that the ventricular tachycardia will be regular, but that's not necessarily true. So this patient, if I look at this, that what we are mentioning, that there is P wave, and this P wave did not conduct, most probably because it's too close here, same morphology, didn't conduct. And this is the baseline ECG of this patient. This patient had marked first degree AV block with atrial phased rhythm. And then they did EP study on this patient, and they could induce ventricular tachycardia. It had an automatic focus on the left side, producing a left bundle morphology. So the reason the diagnosis, all the diagnosis, we should never put an ECG like this in the exam, but we need to keep in mind that irregular RR interval does not mean it is not ventricular tachycardia. It can still be ventricular tachycardia because of few reasons. One, if it is an automatic focus, sometimes there is something called warm up. That means it takes time to get faster. Second, if it is scar related, if somebody had a myocardial infarction and there is a scar related ventricular tachycardia with a re-entry circuit, they can have two circuits as a part of the same circuit. So one circuit shorter, one circuit longer, and it can give a pattern of bigeminy or some degree of irregularity. So irregular RR interval does not rule out ventricular tachycardia. How about this ECG? The reason I'm putting this, both of these ECGs are similar. Heart rate is 126. That one was about 120. And this is a white QRS, and this also has irregularity. This should be 100% should be correct.
Yeah.
Okay. Well, I think I have confused you all with my previous ECG. Any comment, Atahar or Wadud?
There is no, there's LBBB, it's all right.
Yes.
So the last one is out. Atrial fibrillation with RBB is out. The
Yes.
second is very irregular.
So, but Wadud, very good that you say nobody answered D, which is excellent. That nobody actually said atrial fibrillation right bundle blind. So that's fantastic.
So it's atrial fibrillation is a possibility, or wide complex, so ventricular tachycardia is a possibility. Now we have to look for the morphology criteria. It's not in V1. The concordance is not there. And every decision, I couldn't be sure, but the baseline seems to be disturbed. So that goes out of atrial fibrillation.
Yeah. So
most of the point fits with atrial fibrillation with LBB, sir.
Yes.
That's
So
because it is sir.
exactly, Atahar. Go ahead, Atahar, please.
No, sir. What I'm telling is It is the looks almost typical LBB, that is V1, V6, and the lead one. Then the R on the V1 morphology criteria, also this is very narrow, also V1 and V2, that is irregularly irregular. And so, and the R to S interval is also very, that is a very sharp set, that is less than 100, that is even less than the 50. So most of the points fits for the atrial fibrillation with LBB, sir.
Yes, and I think for future, if you see irregular, even though I showed you that ventricular tachycardia with irregular interval, that is for your academic exercise. But this, if I look at the Qrs complexes, it looks typical left bundle morphology. Small R and deep S wave, and in V6, wide R wave, same in V1. And the initial R wave is less than 1 box. It is less than 30 milliseconds. So this is left bundle, along with irregular RR interval. That puts it, first diagnosis is atrial fibrillation with left bundle branch block. I cannot see any P wave. Sometimes you may confuse this is a P wave, but if you look here, there is no P wave. So when the rate is faster, you can consider the T wave as P wave, but it is not P wave. So this is atrial fibrillation with left bundle branch block. And the same patient, when they convert to sinus rhythm, you can see the same morphology. During sinus rhythm, there is a P Qrs complex, initially sharp, same morphology. I think that's about it. Thank you very much. We should go to the next session.
Dr.
Rafique, I'd like to say one thing.
Yes.
Dr. Rafique?
Yes.
Sir.
Sir.
May I say one thing?
Sure.
Whatever the ECG have shown, that we have found many cases that white Qrs of what may be the cause of this white Qrs tachycardia. In most of the cases, we have seen that if this white Qrs does not coincide with RBB or LBB in lead 1, V1, and V6, mostly it is ventricular tachycardia, unless otherwise proved with something else.
Yes. So I'm just going to re-emphasize what Professor Jalal sir is saying, that if the white Qrs tachycardia does not fit into the definition of right bundle branch block or left bundle branch block, that is ventricular tachycardia. You're absolutely right. I mean, that is a very, very simple rule to remember. If we look at a 12-beat ECG of the tachycardia and there is no right bundle, typical right bundle or typical left bundle, then just think of VT and treat the patient. And then again, if you don't know and the patient is unstable, it is VT unless proven otherwise.
Yes.
Thank you.
Yes.
Tushar.
Sir,
Chat box.
There is a question that one of the participants, Buddha Ganguly, asked. That is, sometimes we found capture bit and fusion bit due to irregularities, we say atrial fibrillation turbulence. How to confirm it as A VT? Sometimes there is a question that how to confirm it, is it A for VT?
What is the question?
Sir, during irregularities, we sometimes found capture bit and fusion bit. So how to confirm whether it is A for VT? One of the participants, he is a medical student of 4th year, he asked the question to sir.
So, I mean, the issue is, first of all, we look at the baseline rhythm. Is it mostly regular? And then I find a morphology that is a little different, and there is a P wave before that. That's capture beat or fusion beat. But if it is grossly irregular, then it is most likely atrial fibrillation is a commonly diagnosed. Second, would be very rarely you can find a VT with irregular RR interval. But even though I have shown these irregular VTs for your understanding. If you find irregular RR interval, then please always consider atrial fibrillation or atrial flutter with variable AV block. That will be the primary diagnosis. For our academic purpose, yes, there can be a VT, that's the whole point, but you will rarely see irregular VT. Thank you.
আমাদের দুটো ইসিজি ছিল স্যার আগে ইসিজি অফ দ্য উইকে
না তুষার এখন তা না, এখন আগে হচ্ছে যে আমাদের মানে অরুণ মাস্কের ইসিজি আছে, সাদিক ভাইয়ের ইসিজি আছে এবং মহসিনের ইসিজি আছে। আমি রিকোয়েস্ট করবো অদূর ভাই প্রথমে অরুণ মাস্কের ইসিজিটা ডিসপ্লে করার জন্য, যাতে আমাদের অফিসার সবাই পার্টিসিপেট করতে পারে। অরুণ
প্লিজ শেয়ার ইওর কেস।
রিভু স্ক্রিন শেয়ার, অরুণ মাস্কের ইসিজি রিভু।
অরুণ, আর ইউ দেয়ার?
না, অরুণ আছে, অরুণ মাস্কে আছে।
Sir, will I start to share?
Yes, Arun Maski is
Okay,
ECG.
sir.
Arun, are you there?
Maski, unmute please.
Arun Maski, are you here?
The Arun's, somebody sent a message, Arun's net is disconnected.
Yes, sir. Somehow he has got disconnected.
I think then I will.
Sir, he will join back. He said his net is disconnected. One of Dr. Virat said that. So will we share later then?
Do.
Tahle Dr. Sadi. Dr. Sadi.
Okay, sir. I'm sharing that.
Yes.
Yeah.
Sir, can you see the screen?
Yes, yes.
No, enlarge it.
There it is, sir.
Wadud bhai.
85 years old male. He was admitted in hospital due to weakness and dizziness, but no symptom. Electrolytes and thyroid profiles were normal. Echo was normal. He was not taking any drug that can lower the heart rate. Now, what is the diagnosis? Our question was, what is the diagnosis? What are the points in favor of diagnosis? And what will be the approach of our treatment?
আমার মনে হয় আমরা মানে দু একজনকে ইনভাইট করি ওয়াদুদ ভাই।
হ্যাঁ, কে বলবেন? কে বলেন?
যেমন আসাদুজ্জামানকে দেখলাম, আসাদুজ্জামান, খন্দকার আসাদুজ্জামান।
আর বিজান ভাই from খুলনা, he is here.
হ্যাঁ, আসাদুজ্জামান আছো? মিজান ভাইকে রাখেন।
Bijan, you here? Asa, do you want to comment? Please unmute. Asad, unmute. Yeah, that's good.
আসাদুজ্জামান, হ্যাঁ।
Can you hear me?
Yes, Asaduzaman, we can hear you.
Yes, sir. What do you...
that there is a twist, seems to be 2:1 block, sir.
2:1. Actually, it would have been long rhythm step. We do not.
Sir?
But then we are having some features.
Asaduzaman.
Yes, sir.
Step 1, move step 2, or 2:1. Among the three, which one will you choose?
Seems to be 2:1, sir.
2:1.
But let's go to the rhythm step in the bottom. The first beat, there is a P before the Qrs complex. The second beat, on the downslope of the T, there is a P wave, which is not followed by any P wave. Then again, P, Qrs, T, P again, long pair segment T, and again on the downslope of T wave there is something in there and not followed by any P wave. The fourth Qrs complex has a P wave before, but again that there is it seems to be 2:1 in there. In the V6 also it's clearly seen.
Can it be movie step 1, Wadud bhai?
Menna.
Answer this one.
Movie step 1.
Movie step 1, do you disagree? Movie step 1?
I think it is movie step 1.
Maybe so.
Develop movie step 1.
I want to add something against MOBIS type 1 because in the bottom panel where arrows are given, you will PR interval in the second bit very short, then very wide next bit with the irregular Qrs complex in position, and then again it is shortened. So it goes against MOBIS type 1 as there should be progressive lengthening of the Qrs complex.
Jamil, there is a variety of MOBIS type 1 that is 3:2 or 2:1 like this. Can this pattern fit like this? The bottom is see that is the 2 then sinus. But it does not strictly follow the criteria of the MOBIS type 1 in all the ECG. That is all the complexes.
It seems to me it most likely is 3:1.
Wadud ভাই কিছু বলবেন মনে হচ্ছে।
কিছু বলবেন? লিড 2 থেকে কিন্তু PQS গুলো ভালো দেখা যাচ্ছে। মুশকিল হয়েছে এখানে কখনো দেখা যাচ্ছে এটা 3:2, কখনো তারপর দেখা যাচ্ছে মনে হচ্ছে 2:1.
Seems to be MOBIS type 1, sir.
MOBIS type 1 then মানে 4th and 5th complex গোবিন্দ
স্যার এটা লংগেস্ট স্ট্রিপ রিদম স্ট্রিপ যদি হতো সেটা হলে ভালো হতো।
না
এখানে লংগেস্ট তো রিদম স্ট্রিপ নেই।
But you see the 1, 2, 3, 4, 5 complexes. The 1, 2, 3 complexes fit, but the 4th and 5th complexes does not.
Now, if you consider lead 2, then this P wave is conducted, then this P wave is not conducted, and this P wave is conducted, this P wave is not conducted. And if we consider lead 2, then 2:1. And if you consider the bottom strip, then MOBIS type 1. It is very much difficult, puzzling.
Sir, আপনি কিছু বলবেন?
You can see the rhythm strip in this ECG actually.
Yes, actual rhythm strip is not present here. Longest rhythm strip, it is.
There is a follow-up ECG.
Okay, can you hear me?
Yes, sir.
Okay, so let's look at it. Lead AVF.
You're right, sir.
The pointed first arrow that is pointed is a non-conducted P wave.
Yes, sir.
Before that, there is a slightly prolonged PR interval, and then there is a short PR, long PR, and then there is a P wave in the Qrs T wave, which did not conduct. And then there is a P wave with slightly prolonged PR interval. So even though the number 4th Qrs PR is longer, but by definition, this is MOBIS type 1 AV block. Why it is happening? Probably there is preferential conduction that there is part of the AV node is a little bit more time. And then it goes to 2:1. And then if you look at lead V1, again, first P wave is conducted, second did not conduct, third conducted, fourth P wave prolonged PR, fifth did not conduct, number 6 conducted. So if I put it in the exam, only choice that is available for us for this diagnosis is Wenke AV block.
Yes.
So it is not MOBIS 2, it is not complete heart block, and it is not first degree AV block.
Sir, if I consider this is a high grade AV block, sir, for academic discussion, sir, the high grade AV block is because this is the purely conducted sinus beat. This is purely the RR intervals are irregular, sir. These PR intervals, these PR intervals are not similar. This looks as typically the sinus beat. This one, but
we cannot see your arrow. You have to tell us which lead you are looking at.
Sir, bottom lead, sir, that is AVF.
In AVF. Why don't you look at lead V1? That's much easier to see.
One better.
Dr. Rafique, can it be wonky-back phenomena with little bit of sinus node dysfunction?
Well, the sinus node is functioning fine because the sinus rate is good. But the question was,
but sometimes, but sometimes
PP interval,
the PR interval does not exactly coincide. The PP interval, or you can say the PR interval here also does not exactly coincide with the wonky-back phenomena, but it is wonky-back phenomena with maybe due to addition of mild degree of sinus node dysfunction.
So in sinus node dysfunction, there should have been some variation in the PP interval. Here, look at the V1, PP interval are fairly regular.
Review Sadi ache, Sadi bhai?
Variable, and there are some missing P not followed by any Qrs complex.
I want to come back to Atahar's comment that Atahar, why did you want to call it high grade AV block?
Sir, as because sir, PP intervals are fixed, R are variable, and PR are variable. By definition, sir. Actually, for academic discussion, that is this is the sinus beat, but I cannot follow.
Which read are you looking at?
Sir, V1, okay. Sir, V1, and actually it does not follow the that is the typical sequence of type 1 movie step 1 AV block.
Okay, but okay, let's look at again. I am going to mention about this lead V1. First P wave is conducted. Second P wave did not conduct. Third P wave conducted. Fourth P wave conducted with long PR. Fifth P wave did not conduct. Sixth P wave conducted with a long PR. So majority of the P is conducting. We cannot call it high grade AV block.
Yes.
So our choice will be, am I going to call it Wenkeba, or am I going to call it a Mobis 2 second degree AV block? Now, if I did not have that PR prolongation part and you gave me only the part with 2 to 1, I'll just call it a 2 to 1 heart block without telling whether it's Mobis 1 or Mobis 2. But I cannot call this high grade AV block. If you remember last week, we had an EKG whereby 4 or 5 complexes did not conduct at all, and then there was a conducted Qrs complex. That will fall into the definition of high grade. I'm not sure this one, any of our panelists will agree with the high grade AV block.
Oh, yeah. So now the point is, what will be the approach of treatment? This patient did not have any history of syncope, but quite elderly, but he had complaint of weakness and dizziness, but electrolyte, thyroid, everything is quite normal.
Okay, so
the point is, this patient a pacemaker or not?
Whose ECG is this? Who brought it?
Sadi bhai.
Sadi, is he there?
Sadi bhai. Can you look for Professor Shubhra? Can you look for Professor Mukaddas and Sadi?
Sir is here. Sir is here. Just give me 1 minute, sir.
তুমি সাদি ভাইকে ডাকো।
Do we have follow-up ECG?
Yes, follow-up ECG.
Now, one of the things that we do, 85-year-old, if they come with syncope or pre-syncope, that's one story. Dizziness is such a vague symptom. It can be from many, many causes. That's one. Second, what I do with this kind of patient, I make them walk to see what happens to the AV conduction. If I make this patient walk and AV conduction gets better and the patient is still dizzy, it has nothing to do with the heart rate. I doubt very much that his dizziness is anything to do with the heart rate because I calculated it. When it is 2 to 1 conduction, his heart rate is 55. That is not a slow heart rate. So that's one thing we do. Second, what I do is if somebody comes with bradycardia and let's say somebody comes with this heart rate or sinus bradycardia with heart rate 45 or 50, I give them a Holter monitor.
Yeah.
And if I find they wrote dizziness 10 times and the heart rate was 50, and the rest of the time their heart rate was 40, 45, 50, no symptom. So I don't believe in that case that the heart rate is anything to do with the dizziness. So you have to clearly correlate the symptom with the ECG. In this case, I'll be very careful before I implant a pacemaker, unless I can definitely prove that the patient has symptomatic bradycardia.
So our first task would halter and correlation with the symptoms during the halter.
Yes, and make the patient walk and be active. So I can tell the patient wear the halter, go up and down the stairs, go out for a walk, and write it down on the diary. See what happens. Okay, so let's show the follow-up ECG.
আমি ওনাকে পাঠাচ্ছি স্যার, কিন্তু স্যার এখানে আসছেন না। আমি আরেকবার দেখছি স্যার। একটু ওয়েট করুন স্যার।
দেখাও।
জি। স্যার ইসিজিটা দেখাবো?
Is Arun follow-up ECG please? And Arun, if Arun is on the line, let's get Arun.
Is Arun ready?
Sir, here is the interpretation.
No, এটা বাদ দাও, এটা হয়ে গেছে।
Okay, sir.
Follow-up আছে।
Follow-up,
sir, here.
আগে ECGটা দেখাও।
This one. ECG.
This is the follow-up ECG, sir.
So this shows sinus rhythm with borderline first degree AV block. So is Arun here?
Calling him, sir. Show us the second ECG. Till Arun is here, we can see the most grateful ECG. Review, are you there? Arun, তুমি কি ঢুকতে পারছো? Hello.
Yes, sir. Yes, sir. Sir. Internet is very unstable, sir.
Let's try it.
Yes, sir.
All.
কারণ কি ওরা বলছে যে আপনাকে লিংক পাঠাইছে।
That's the problem.
আপনি ভিডিও অন করেছেন?
If you can show us the Professor Mohsin Hossain's ECG.
Yes, sir. Showing, sir. Here it is, sir.
And if I arrived, Mohsin, can you describe the patient?
These patients came with these referred by some pediatric cardiologist to me. 15 years old female. He has ventricular septal defect, and present to the ECG, he does not have any symptom. So does he need any pacemaker or not? That's why he sent the patient to me. This is the ECG.
So what you want to know? Diagnosis or management?
Diagnosis and as well as management, sir. Mainly management part.
Now, what is your diagnosis?
This is a complete heart block, congenital complete heart block associated with VSD.
First, second, third. Sir, what is the fourth beat, sir? Lead one, first, second, third, fourth, fifth beat.
I mean, fifth beat, probably the ventricular premature beat is just a coincidence. And the other thing that you could have thought of is WPW syndrome. But if patient had WPW syndrome, you would have seen pre-excitation in other places, and it would have conducted one-to-one. So it's just a premature beat. So but one of the things that it's a narrow QRS escape rhythm, complete heart block. From ECG, I cannot tell congenital complete heart block. The diagnosis will be complete heart block with ventricular premature beat. Management-wise, I mean, it's a 15-year-old. Eventually, a lot of these patients need pacemaker. However, I had a patient I just saw. she is now 60-year-old and doing fine without a pacemaker. One of the things over here to note that this patient has underlying sinus tachycardia. So what is happening? The body is telling the heart to increase the heart rate. That's one problem there. What we do echo on this patient. We wait. If the patient is asymptomatic, we continue to do echocardiogram. And if at any point we see that there is dilatation of the ventricle, that is the time when we implant a pacemaker in this patient. Otherwise,
There is a mild LV dilatation is there.
the LV is dilated, right?
LV is mildly dilated.
Yes.
Mild dilated and ventricular septal defect.
Yes. So if LV starts dilating, then it is a good idea to put a pacemaker. And 15-year-old probably has grown enough. I mean, if the patient, the reason we delay this is because if you put pacemaker in young people, they get taller, and then you have to put new leads in. If we try to delay as much, and the patient has no symptom at all.
No symptom at all.
I mean, I would probably wait a little bit and keep follow-up echo every year. How big is the left ventricle?
Left ventricle is mildly dilated and LV mildly dilated, but LV function is good. But RV is very small.
Yes.
Physiologically, RV is very small.
Okay. I mean, so there is no shunt.
There is a VSD, ventricular septal defect.
Yeah, but what is the decision about VSD? Are they going to fix it?
They want to fix it. That's why they send me. If they fix it, how to fix the rhythm fast or the VSD fast?
Sir, the surgeon will most of the time will not do the surgery without pacemaker, sir.
Yeah, so that's the problem, yes. But then again, if you put a pacemaker in, the surgeon may dislodge the pacemaker. You understand? So,
Sir, I would suggest that the surgeon can use epicardial temporary pacemaker during the repair, and later, after the repair of the VSD, a permanent pacemaker can be.
absolutely. So, I think I agree with Jamil, because this is the problem. Let's say I put a pacemaker in today, and the patient gets surgery within 3 months. There is high likelihood of dislodging the lead, number one. Number two, even if the surgery is done after 2 years, when they put clamp, I have seen surgeons damaging the appendage and damage the lead. So I totally agree with Jamil that I think they should go ahead with the surgery with epicardial lead, and after surgery, evaluate the patient to see how it is, and re-evaluate the need for pacemaker. And at that time, put the permanent pacemaker in. I will not do it before the surgery.
As the patient is young and she has got the VSD, so it is likely that the congenital heart block is heart block is usually associated with the VSD, that is the congenital, or we should do the further more tests to evaluate the other causes of the VSD, sir. Sorry, heart blocks are here. No,
I think it's related to the VSD. I don't think we need to do any other evaluation unless if patient had SLE or some other thing, you would have known by this time. But the question is the timing. Timing, I think surgery should be first, followed by pacemaker if we make a decision on that.
Mohsin, your description and your decision. Ribhu, can you show the rest? Ribhu?
Yes, sir. There is no description given. Just a question.
As a Mohsin is here, he can describe.
No, this is the main thing, the management part. There is some PPE sometimes irregular. So there is some ventricular phagic sinus arrhythmia there. If we can look carefully, PPE is sometimes irregular. PPE enclosing the Qrs complex is shorter without PPE, without the Qrs complex. There is some ventricular phagic sinus arrhythmia also there. If you can look carefully, I have given the ECG by measurement. Can you show me the review? Can you see that? I have given this.
The উত্তরটা দেখাও.
Sir, will I stop screen share?
তুমি এর পরের উত্তরটা দেখাও না এটার.
Sir, answerটা নেই স্যার.
Next slide.
আতার ভাই আপনি ওকে পাঠান নাই আনসারটা?
না, মহসিন পাঠাইছে তো.
আমি ওকে পাঠাচ্ছি তো.
Sir, এটার
Mohsin, how is the right atrium?
Right atrium is normal.
Yeah.
But RV is very small.
Okay.
রিপুর কাছে নেই তোমার আনসারটা, ওই যে খুব সুন্দর করে লিখে ইয়েটা পাঠিয়েছিল সব ডিটেইল।
Okay, I think we should move to the next. Okay. Shall we move to the next one?
আচ্ছা, অরুণ মাস্কি?
Arun is actually out of Kathmandu. He was that's why he is out of range of Wi-Fi. He was trying to contact us through his hotspot, but still not getting succeeded, I think. Ripu is.
Let's do it next time.
Yeah, in that case, we will try that. Sir, regarding the pacemaker, I have done pacemaker in a patient, and that patient, he has biphasic with intermittent and symptomatic. Several years ago, and was advised for pacing, but as he was symptomatic at that time, he did not agree to do that. And last 2 years ago, he again had a history of become unconscious, and we put a pacemaker in him. The interesting point is that in that patient, while doing the temporary pacemaker, we have to go through the mitral valve into the morphological left ventricle going into on the right side, and so that creates a little bit of problem. Again, while entering, because there is no trivesicular valve, there is a bivesicular valve. Again, it needs a little bit of manipulation. Again, during permanent implantation, same thing. A little bit of manipulation was needed, but after putting on the pacemaker, the patient becomes totally asymptomatic. Yeah, well.
That's great. Okay, I think, are we done today?
Sir, just a question from me, sir. In case we need to put pacemaker in a patient who has to undergo bypass surgery or open heart surgery, is it better to do the surgery first, then the pacemaker? Because if we do the pacemaker or any device earlier, and the patient has to go bypass surgery later, does it increase the infection rate of that patient? Does it put extra load on him? You know.
I mean, you are talking about doing the pacemaker before or after?
Before and after. If we do if a patient has to undergo bypass surgery, open heart surgery, and he also needs pacemaker.
Saying, if a patient need to have a pacemaker as well as bypass surgery, should pacemaker first or should we do the bypass first and go for the surgery, a pacemaker implantation?
Yeah. We usually do the bypass first. And then before the patient goes home, the day before patient is discharged, or surgery day 4 or 5, we will put the permanent pacemaker in. Because again, the same theory, during procedure, it is most likely that the lead will get dislodged. So we don't do it.
Sir, does it also decrease the infection rate? The risk of infection is lower in that case?
No, we are not considering that point at all, because I'm not going to do it before the surgery. I'm not delaying it because I have less risk of infection. I'm delaying it because the lead will get dislodged during the surgery.
And during surgery, the epicardial lead is there, so you are not putting the patient in danger.
Exactly. But I'll give you a reverse scenario. Somebody needs transcatheter aortic valve placement and needs pacemaker. In that case, we put the pacemaker first.
Okay.
Yeah.
Because 2 reasons. One, they are not going to go to the right side. And as a matter of fact, a lot of patients with TAVI needs permanent pacemaker. So putting a pacemaker in those scenarios, we put the pacemaker first because they are not going to disturb the right side at all.
So it's around 4%, isn't it, after TAVI?
Well, it used to be more than that. It used to be up to 14%. But depending on the valve type, we do a lot of, our center have done about 400 TAVIs, and it's about 10%. So when they develop, yeah.
Electronic valve has more problem, Ravi.
Huh? Or can you share a case? Or unmute, please.
Just trying my best to.
Oh,
yeah, it's coming.
Time.
Is that?
Yeah, we are seeing it. Describe it.
Yeah. Before
Okay.
Nate goes, I'll just give you a brief history. This was a. Is it coming?
Yes.
Yes.
I have a lot of net problem. I don't know whether I can continue or not. This is a 71-year male referred for bradycardia. No risk factors, ejection fraction is normal, no echo. Plus, he has some past history of dizziness, and otherwise asymptomatic. He's a retired police officer. So this was the ECG of the patient. I mean, you can see here sinus bradycardia, inverted P waves in inferior leads, rates around 32 to 54 beats per minute. And
There is also old MI interceptor, is it?
when ECG was done, this rate is again around 30 beats per minute. During daytime, one of his showed heart rate of 28 minutes. This will worry some. Discuss about this patient. As our discussion with the electrophysiologist decided to put pacemaker in this patient.
Because the Arun, can you show the screen? Arun, can you show the share the screen?
Again disconnected.
We have better present this in the next day, sir.
Yeah.
Interesting case.
Arun? Only again disconnected.
Sir, his net connection is not good.
Arun, you are disconnected again. Can you show the screen again? No, the last one, last ECG, second ECG. Yeah. Sir, the P wave of the third it is not from the sinus node. The first two P waves seems to be probably from the sinus node, but the third one is not.
Yes.
Same is true of the. Escape P wave. And the sinus P node. Can you see? আতার ভাই আজকে মনে হয় এটা আমরা নাই দেখাই না।
হ্যাঁ, অরুণ যেহেতু ডিসকানেক্টেড হয়ে গেছে। আচ্ছা,
আগামী সপ্তাহে ডিসকাশন হবে। ইন্টারেস্টিং আছে।
সাডেন ইনপুট চাচ্ছিলাম এটার ব্যাপারে।
Next week করো অরুণ, better reception হলে we can talk about it. This is a classic 6 sinus syndrome patient. I think we should talk about it next week.
Govindo,
may I ask any question, sir? Atahar sir, Wadud sir, am I permitted?
Of course.
আচ্ছা, গোবিন্দ স্যারকে একটা কোশ্চেন করতে চাচ্ছিল, করো গোবিন্দ করো।
To Rafique Ahmed sir. Sir, in case of VT, concordance in chestlet, concordance points in favor of VT, but in discordant is against VT. Why? What are the reason?
Okay.
Concordance in chestlet points in VT.
Arun, for a little bit. Arun, I think we better show the interesting case next week so that we all can enjoy it properly. That will be better. If we stop sharing. Go on.
Sir. Regarding concordance and discordance criteria, VT criteria, what are the...
Okay. So I think I'll answer this question. Arun, we will do I think your reception is poor, so we will do it next week so that we can enjoy this case when you at a better net zone. So, Govinda,
yes, sir.
the presence of concordance supports VT. Discordant does not rule out VT. So having concordance means that it is ventricular tachycardia. But if it is discordant, that does not mean that it is not VT. Then you have to use other criteria for diagnosis of ventricular tachycardia.
Right, sir.
Okay, sir. Thank you, sir.
Nice question, Govindo.
Thank you. Nice question. Yes. Any other question?
আজকে মনে হয় না আসছে।
আচ্ছা, আমার মনে হয় শামীম ভাই আছেন, আমাদের শামীম ভাই, ফরিদপুরে শামীম ভাই।
স্যার ছিলেন
আচ্ছা স্যার,
আগে চলে গেছেন।
স্যার আজকে আমরা ওয়াদুদ ভাই, আজকে আমরা আসাদুজ্জামানকে ওয়েলকাম জানাই। আসাদুজ্জামান, থ্যাংক ইউ ভেরি মাচ আজকে তোমার জয়েন করার জন্য। আসাদুজ্জামান স্যার আমাদের খুব মানে ভেরি লিডিং স্যার ইন্টারভেনশনাল কার্ডিওলজিস্ট এবং ভেরি একাডেমিক পারসন স্যার আসাদুজ্জামান আজকুর আলী হসপিটালে আছে। আসাদুজ্জামান উইল বি হ্যাপি যদি তুমি আমাদের পরবর্তী সেশন।
Sir, actually I join in every sessions, but I get the opportunity to your face, sir.
Nice looking, my friend.
Sorry, Sadir bhai, possibly you are here, but you cannot fail to. That is, it is a technical problem from Sadir bhai's side that he cannot join with the video.
Sir, may I ask a question to Rafique, sir?
Yes, sure.
I have seen a young lady, 15 years, having complete heart block but asymptomatic. Having a role of pacemaker in this young lady with this asymptomatic.
আচ্ছা, তোমার ইয়েটা ভালো না।
Sir, network is. My question is, if a young lady like 15 years having complete heart block without any symptom, to have any role of pacemaker in this young lady?
Yeah, I think we have discussed similar issue in a, and most likely this is congenital complete heart block in an asymptomatic person. We like to wait as long as we can. We see these patients every year. If they develop symptom or if they develop dilatation of the ventricle, then we do a pacemaker. The other thing I have done, as I mentioned earlier, that I had a 60-year-old female and she said, I have no symptom. But when I put her on a treadmill, she could only walk for 2 minutes. That means she was symptomatic. And so that's when you decide on the pacemaker. But I had young patient, 30-year-old patients, congenital heart block, can walk on a treadmill for 12 minutes without any symptom. There's no need for pacemaker in those patients. So the whole point is to try to delay the pacemaker implantation as much as possible. Eventually, they will end up needing pacemaker.
Sir, another indication for the congenital heart disease, if put on the treadmill, if there is morphologic discordance, incompetence, then it's indication for pacemaker. Right, sir?
Exactly. So that's what I did with my other patients. So she was she had no symptom with daily life. I said, let me put you on a treadmill. And when I put her on the treadmill, her heart rate did not go up. Ventricular rate went up to 60. Her underlying sinus rate went up to 170, and she could only walk for 2 minutes.
Okay.
And so that's basically chronotropic incompetence because ventricle is not being able to keep up with the demand of the body. And she needed a pacemaker. But unfortunately, she refused. I mean, that's fine. You can wait on that. But eventually, this kind of patient will come back with heart failure if you wait too long.
The ECG with untitled complete heart block, you at that point, the actual rate was quite high. The sinus rate was quite high. There was sinus tachycardia. And that's the point the body needs more heart rate. It cannot get it. Isn't it, sir?
Exactly. I look at that. I look at the underlying sinus rate. How is it? If the underlying rate is 130, that means the body is releasing more catecholamine to increase the heart rate, and it's not getting it. Most of the congenital complete heart block, you will see that the sinus rate is probably 90 and the ventricular rate is 45, 50. They're fine. But a relatively younger person like to wait as much as possible. Thank you.
Sir, Sir, in ETT, in this congenital complete heart block patient, how much increase in heart rate or ventricular rate are satisfactory to say that this patient does not require pacemaker at this moment? If we do the treadmill of that patient and we see the ventricular rate rise, how much percentage of rise of ventricular rate is safe to say that this patient does not require pacemaker at this moment? Is there any cutoff? Or,
I don't care about the rate as much as other people. If my patient can walk on the treadmill for 12 minutes and the heart rate goes to 70, so what? On the other hand, patient can walk only 2 minutes, gets extremely short of breath, heart rate goes to 70. There is a big difference. So I think it's the duration of the exercise which is important. Because the ventricular rate will not go as much, because junctional rhythm will go maybe up to 100, 110 maximum. So it's not the heart rate that is important, it's the duration of the exercise which is important and symptom associated with it.
That is the functional capacity is the most important thing, isn't it?
Yeah.
Now,
thank you, sir.
Wrap up today.
Yes.
Would you give some concluding comments? জালা স্যার কনক্লুডিং কমেন্ট করতে বলছিলাম। স্যার আপনি আনমিউট করতে হবে, স্যার মিউট করা আছে, আপনি আনমিউট করতে হবে।
I think everything has been discussed. I don't like to comment anymore. Dr. Rafique Ahmed has shown many beautiful and to know many things new about the wide QRS complex, where I think everybody is benefited from this session.
Thank you, sir.
Thank you.
Okay. I thank Dr. Rafique very much to show so many cases of very interesting things to diagnose and treat the patients.
ঠিক আছে অত ভাই।
আচ্ছা ভাই আপনি শেষ করবেন।
Sir, finally, we like to thank Rafique Ahmed sir. Really, actually, we are waiting for this session. Actually, wide complex tachycardia always this is a session. Sir, today your actually presentation was, I think, more enjoyable and more beautiful, sir. Actually, I think our participants have benefited too much today. And today we also congratulate Dr. Khondokar Asaduzzaman. Asaduzzaman, we are really very happy to see you. And I want to congratulate our participants from Faridpur. Possibly there are so good number of participants in front of the big screen in Faridpur, sir, headed by Dr. Professor Shamim Ahmed. Shamim Ahmed, bhai, if you are here, we must congratulate you, and we have to have you in our every session, that is every Saturday. So in next Saturday, sir, there is again, that is the ECG on the electrolytes and metabolic disorders. That will be actually Dr. Khaliquzzaman, sir. Part of the lecture was delivered the previous Saturday, and the rest part will be on the next Saturday. That is electrolytes and metabolic disorders by the Khaliquzzaman. So possibly, I think we can conclude the sessions today.
Thank you.
And we must thanks our Hafiz bhai. Possibly he was in the early part of the session, possibly not, but we are very much happy to see the Hafiz bhai every day. Hafiz bhai, if you are here, we can want to see something from you.
Sorry, আমি clinic করতেছি, সুতরাং in and out, so I apologize for.
Achha, no problem, but we want to see from, some ECGs from you. If you get chance, then you can show your ECG. We'll be happy.
I can show this if you let me know the topic beforehand. Then.
Achha, topic next day: electrolytes and metabolic disorders. Next Saturday.
Okay.
Hafiz, can I suggest that if you could get some ECG with acute MI and bundle branch block, right, left bundle, that will be a very good thing.
Yeah.
We have plenty.
Your own, and with the angiogram picture. So bundle branch block ECG with acute MI and with the angiogram, that will be fantastic.
So Tushar, so we can conclude the session today, sir.
Thank you. Thank you very much.
Thank you, sir.
Thank you all.
Thank you all the participants and respected teachers. Next Saturday we will again meet and have discussion on metabolic and electrolyte disorders. Thank you all.
Thank you. Good night.
Good night,
Assalamu
Dr.
alaikum.
MedStar.
Waalaikumsalam.
Thank you, Abdul.
Assalamualaikum.